All right, Michelle, this is your show.
All right. So I was thinking we could wait maybe just like 10 more seconds before we get started, just to see if there's more people on. All right, we can get more people to join when they're ready. So thanks to everybody for coming. Before we formally get started, I'd like to give a little bit of background about this presentation and the Ethics in IR initiative. So this is the first of a series of webinars that this group, the Applied Ethics in Palliative IR Education Committee, which is supported by the Society of Interventional Radiology and the Society of Interventional Oncology, is doing to help facilitate the ethical discussion within the IR community. So if you're interested in learning more or being part of the group, there will be resources and contact information at the end of this presentation. And this presentation is meant to be interactive. It's a little bit difficult with this webinar system to be able to do that, but the process that we plan on doing at this point is to have people write their names and their interest in speaking up when the cases come up, and then we can go from there. So without further ado, this presentation is titled Ethical Considerations for Interventional Radiology Residents During COVID-19. Oh. And I don't have any disclosures. I'd like to thank Dr. Eric Keller, a second-year IR-DR resident from Stanford University, and Dr. Mina Makary from Ohio State University, who were both crucial in every step of this project. Eric is the mastermind of the Applied Ethics in Palliative IR initiative, and I'm grateful to be able to call him my colleague and friend. And both Eric and Dr. Makary edited the presentation and created a lot of the content for this presentation and the co-authored article that it's based off of. So this is the article that we published in JVIR, and if you'd like to learn more about this topic, you can go to this article. Most of the cases we go through are actually going to be directly from this article. So for our learning objectives, we're going to define several ethical principles and go through them using a case-based approach. My goal is to help you develop practical tools to deal with ethical issues at work and know where to find ethical resources when needed. Some of you might be wondering, why should we discuss ethics in our field? First of all, IR is a field of innovation, and with innovation comes ethical inquiry. Research ethics is a huge topic in the ethical realm, which encompasses topics of conflict of interest, beneficence, non-maleficence, and autonomy. And once a new tool has been developed, the allocation and distribution of that technology can be ethically questionable. Also, given the majority of our patients have chronic conditions and may be palliative, we're often put in ethical dilemmas in deciding if a patient's care is futile and if patients have decision-making capacity. Every time we consent a patient, we must assess if we've provided the patient with enough information to make an informed decision. Given that many of our patients are at the end of their lives, it's not uncommon for residents and physicians to experience moral injury associated with futile care, and we'll talk more about this later. Also, procedure diversity uniquely merges the field of IR and ethics. Since IR covers such a large range of procedures and there are a limited number of fluoro suites and time in a day, deciding which patients take priority and when to perform a case requires constant evaluation of resource allocation. So as you can see, there's a great deal of overlap between IR and ethics, and we hope to touch on many of these topics today. So why should we care about ethics as residents? There's little formal training in ethics in both medical school and resident education, but ethical issues involve residents all of the time. Residents are actually a vulnerable population, and they're often put into ethical dilemmas. This is due to the fact that they're put in conflict between patient interests and hierarchical structures. For example, deciding what to do when your medical opinion is different than your attending's can be challenging, and following through on an attending's wishes, despite your personal thoughts, can lead to moral injury. Residents are often involved in life-changing decisions for a patient, and without formal training in both ethics and palliative care, these ethical issues can be even more difficult to manage. Furthermore, many residents will be taking on leadership roles both within and out of training, and deciding how to manage limited resources could be part of our jobs. Residents are often physician scientists and thus will always have ethics be part of their jobs through research. So now I hope you can see why this topic's important, and we'll transition now to a little background on ethics. So what is ethics anyway? In a strict definition, ethics provides standards for behavior. It helps to answer the questions of how should I act in a range of situations and why should I act in this way? There's different sectors of ethics, and I'm not going to go too far into the weeds, but ethics can be divided into 3 camps. Meta-ethics helps to uncover the nature of what's right and wrong. Normative ethics sets standards and principles, which is used to determine if something is right or good. And applied ethics uses ethical principles in various situations. Often, applied ethics helps to form the standards and principles of normative ethics. In addition to these 3 camps, there's various theories on how to approach ethics. So consequentialist theory relies on ethical consequences, and oftentimes people know utilitarianism, which falls into this camp and focuses on making decisions that result in the greatest amount of good for the most amount of people. Non-consequentialist theory focuses in on intentions, which calls on acting in alignment with duty and the justice system. Lastly, agent-centered theory takes an approach based on ethical status. For example, the virtue approach would make decisions based on what someone who is seen as virtuous would do. So from a practical standpoint, it can be useful to have a decision-making framework when faced with an ethical dilemma, and here's one approach. First, you should realize that there's an ethical issue at play to begin with. Second, you should consider who might be harmed and who may benefit. Next, you want to gather all relevant information from all involved parties. And then you should evaluate your options using the theories that were described on the last slide. So for example, a utilitarian approach to an ethical problem works to answer which action will produce the most good and do the least harm. A rights approach would act in alignment with whatever decision respected the rights of all involved. A justice approach seeks to treat people equally or proportionately, and the common good approach tries to pursue an action that serves the community and not just some of its members. And a virtue approach seeks to answer which actions leads me to act as the sort of person I should be. So once you've considered all these options, you have to decide and act. And then finally, it's important to reflect on the outcome of this action and analyze if this approach was most optimal. So COVID has put additional pressures on the medical community, and residents are no exception to this. We'll briefly go through some examples of how residents have been impacted. One study, which was done using a national Canadian survey, demonstrated that during the peak of COVID earlier this year, there was 74% decrease in case volume for trainees based in Canada in this survey by at least 15%. 24% of fellows delayed starting their careers as IR attendings, and 35% of residents delayed their fellowship training. Also, learning in residency has drastically changed for many specialties, as I'm sure you all know, with remote learning becoming commonplace for all. Also, in areas where COVID overwhelmed hospitals, residents were asked to be redeployed, taking time away from their regular duties to help take care of patients, all the while risking their own health and safety and the safety of their families. Some residents were fast-tracked into attending status, being forced to make decisions possibly before they were ready to take on that responsibility. Many residents experienced fear for their own health and felt immense guilt and fear infecting their families. And residents who matched away from their families were often forced to quarantine alone, and those who were working in high-risk locations were forced to sleep separately from their families. So all these things lead to complete isolation during such a stressful work experience to begin with. Also, residents had to watch COVID patients die despite all the medical support that was offered to them, and many residents have suffered from burnout as well. So as you can see, residents have been significantly impacted by the COVID-19 pandemic, as many other health professionals have, and some of the issues that residents have had to deal with, like fear of one's own personal health and the health of family members, leads us to an important ethical question. So this is the question that arises: do we have a duty to treat? And this is the part of the presentation where we were going to go over some cases. So it's going to be a little bit of a trial and error here with leading to our comments. So if you would like to answer the question to this case, please just write your name in the chat, and then we will give you control to be able to speak. So I'll go ahead and read the first case. You're on call and a patient presents to the emergency department with an aortic dissection at the peak of the COVID-19 pandemic. A rapid COVID-19 test is performed and the patient is positive. You have a newborn at home and your wife has multiple sclerosis on immunosuppressants. Your co-resident lives alone and you know they're free tonight. So do you perform the endovascular repair or make a call to your colleague? So if you have an opinion or a thought on this, please write your name in the chat and we'll give you access to be able to answer. Ahmed, has anybody volunteered?
Doesn't look like it just yet.
Okay. Well, in the meantime, while we're waiting, I can kind of touch on some of the issues that might come up when trying to answer this. So if the questions that come up and some of the issues are related to also the timing of when the situation came about. We have Eric on the line, so it looks like he might be interested in answering.
Hey everyone. Yeah, I mean, I think this is a tough situation, you know. I mean, you haven't necessarily entered into a contractual relationship with that patient, so it's not like you are legally obligated to treat them. At the same time, we do have, you know, an ethical duty to serve people in the profession that we're in. You have your colleague, but they also, you know, you don't want to throw them under the bus either. I think you could totally do like a middle ground, more of that, you know, virtue approach that was discussed earlier. Is maybe you could say, you know, we all want the best for our colleagues, we all want the best for each other as co-residents, and maybe broaching that conversation with your co-resident, maybe they'd be happy to, and you wouldn't know if you asked the question. I definitely don't think it'd be right to force them into it just because they're in a different social situation than you are.
Yeah, I agree. And I think some of my co-residents who I've chatted with have expressed the fact that although they don't have families yet, they don't feel like that really warrants being forced to put in higher risk situations just because they haven't chosen to pursue starting a family at that point in their lives, which I thought was an interesting feeling and approach. Anybody else have any other thoughts on this? One other comment I just wanted to make is I think that the timing of when the situation would come about is also changes kind of the approach, because I would say earlier on in the pandemic when we didn't have as many resources and N95 masks, I think people felt more afraid of being exposed because there weren't really standard protocols and people didn't really know how to protect themselves as well. Now that we have kind of more protocols of how to take care of COVID patients, at least in our hospital, we have kind of a standard approach. I think more people would probably err on the side of going ahead and just doing the treatment as opposed to calling somebody else in. But earlier on, when it wasn't so clear cut, I think people would probably think about the option at least of calling and maybe asking to have someone come in. So it's difficult, but I think overall you have to kind of weigh the costs and benefits. All right, so we'll go ahead and I'll move on to our topic based off of that case. So duty to treat is this concept that I was hoping to get across with that case. So the ethical dilemma of whether a physician has a duty to treat was a major topic during the HIV/AIDS pandemic, and there was a mixed response from the medical community at that time. Only after there was more clarity about transmission, similar to what kind of happened with COVID, did the AMA and other major medical organizations say that we do have a duty to treat. Although of note, the literature consistently states that the general community always feels that medical professions do have a responsibility to treat and should not be denied care. The Society of Interventional Radiology does have a code of ethics, which reads, interventional radiologists shall, except in emergencies, be free to choose whom to serve, with whom to associate, and the environment in which to provide medical services. Discrimination is inappropriate and illegal. And the AMA has a similar code that was listed here. Now, some people might claim that a pandemic qualifies as a state of emergency, and therefore physicians under the code of ethics have an obligation to treat. But it's kind of questionable, does this apply to elderly physicians who have comorbidities and have a high risk of death? It's not so clear if you're ethically bound. And interestingly, from a legal standpoint, physicians are only obligated to treat a patient once they've entered a therapeutic relationship, like Eric had mentioned. Overall, there's a general consensus that the medical community has a duty to care for the general public during states of emergency, but there's nuances and exceptions to this duty, especially when one's own health and safety is at risk. So before we move on to our next case, are there any kind of thoughts on this topic or other approaches to the case?
Michelle, can you hear me?
Yeah, I can hear you.
Hi, this is Sarah Silverstein. I think you and Eric both raise a good point about how we approach fiduciary duty and entering that that obligation to the patient. And typically, this is talked about on an individual level. Like we talked about the obligation to follow through with a therapeutic relationship on a provider to patient level. But I'm wondering if, when we talk about residents in particular and the ethical dilemmas that residents face, if we actually need a different framework and we need to approach it from a more team-based perspective. Because thinking about the what you brought up in the first case with, you know, can you call on part of your resident team? Can you pull from the pool of residents? That, I think that's a different question than if you were an attending and asking yourself, do I have to care for this patient? And so I'm wondering if when we talk about residents in general, if we need a different framework than we classically approach this topic with.
So I think you raise a really good point, and I think it's actually not so specific to residents in my opinion. I think that in general, taking the team approach is a really good way to approach duty to treat, because from the perspective of us as a medical community, I think it's pretty clear that the medical community has a duty to treat patients within a pandemic. I don't think that that's really disputable. It's just more on the individual level. How do you make your own personal decisions? So as a group, I think it does make sense to kind of band together and decide where can we put somebody who has kind of higher risks, how can they still contribute without necessarily being in the line of fire and being in a situation that could really significantly harm them, as opposed to somebody who has kind of lower risk, who might be able to kind of step up and be in that front lines. So I think you're right on to say that this should be something that we look at more as a group as opposed to just as an individual. Thanks for your comment. All right, so we'll go ahead and move on to our next case. So we have a 78-year-old female patient with a recent stroke and stage 4 metastatic small cell lung cancer. She's been on the ventilator for the last 2 weeks with COVID-19 pneumonia. You're consulted for a gastrostomy tube placement for long-term nutritional support. How do you respond to the team's request? So like I had, for anybody who's just jumped on, if you have something to say about this case, please just write your name in the chat and we'll add you as a panelist to be able to speak up.
I can start the conversation, I guess.
Sounds good.
I feel like in IR we often, I mean, COVID-19 or not, get a lot of these requests as kind of being seen like the Hail Mary pass of healthcare sometimes. I mean, this seems like more of an acute thing, but I feel like it's always worth, and it's hard when you're busy on a consulate service to ask the question, but you know, like what's the end game here? Like, is this person critically ill, and does this align with this person's goals of care? Has anyone had that tough conversation? Is this someone who, you know, might not live through it, so you're just putting them through another procedure and they're ultimately going to pass away in the ICU? Or is this someone who's likely to, you know, to be fine? Or is it someone in between and we don't know, but it's still worth having that conversation of how invasive of care you want, and giving people that agency to be an advocate for themselves, even, you know, maybe as a family, as a surrogate decision maker if the patient can't speak for themselves. And I feel like sometimes in the busyness of healthcare, it's very easy to put in the consult. It's very hard as the consultant to then go back and ask that question and be like, oh, has anyone had that conversation? I actually just had something, not COVID related, but with IR, very similar to this, where I asked them, it was someone with like end-stage cancer, bad complication of a surgery that needed like perc neff tubes. And I asked, you know, oh, has anyone had this conversation with the family? And they're like, oh yeah, we've had like a goals of care discussion, whatnot. And I was like, oh, okay, great. And I call up the son, who's like the surrogate decision maker. And I'm like, oh, you know, so your dad, you know, here with cancer and everything else. And they're like, oh, when's he coming home? And I'm like, oh, wow, we need to like step back because he's been in the ICU for 2 weeks, you know, because with COVID, there's that distance. So I feel like it's worth having the conversation is the biggest first step that this makes me think of.
Yeah, so I think you brought up a really good point right in your last comment, specifically when you had said that you called the patient's family and they had kind of a different perspective of what the goals of care are as compared to what the referring team had thought. So I think that's another key reason why, yes, those discussions need to be had with the patient and the patient's family, but also with the team, with the referring team, so that everybody's on the same page in terms of what the whole goals are. So thanks so much for your comment, Eric. I do think you've touched on kind of the most important thing that I wanted to get across here, which is when we're talking about futility, it's really difficult to assess whether or not a patient is considered futile or not. We'll chat about these definitions in just a second, but I was wondering, kind of in your perspective, Eric, in your hospital, do all patients who are being referred to for a gastrostomy tube, who kind of have like more of a longer term illness, do you guys always get a palliative care consult, or is it not quite as strict of a definition?
We don't, and actually there's to put on my like anthropology hat, there's actually kind of a weird relationship between oncology and palliative care. So it's more common at times that they'll have that palliative care consult if they're not a patient that has cancer, which is somewhat challenging.
Yeah. Interesting. Well, I do think that that's something that requires a little bit of more explanation, or like exploration, simply because a lot of our patients are kind of chronic patients who might have a shorter lifespan, and these conversations should be had. And so if we could develop some sort of standard that might ensure that people are not getting procedures done who wouldn't benefit from it. So something to consider. But back to the discussion of futility, dealing with medically futile cases, as we know, can be challenging. And there's something called quantitative futility, which we can define in one way as less than 1% chance of achieving a physiologic benefit. And given the fact that it's so hard to assess what is considered futile and to put that number down, people weigh qualitative futility a lot more heavily when they're deciding whether to pursue an intervention. And qualitative futility is determined based on the ability of a patient to achieve, or the ability to achieve a patient's or family's goals. So it's more goal oriented as opposed to kind of numbers oriented. And if faced with a dilemma involving a medically futile patient, it it would be worthwhile to investigate if your hospital has any protocols to help you kind of make with your medical decision making. So many hospitals actually have guidelines and they also have ethical committees that are specifically designed to help answer these types of questions. This is just a link to one of the guidelines at my hospital at the University of Michigan, and this is a little excerpt that is from the protocol when dealing with a patient that might be futile. I won't read the entirety of it, but I want to highlight that to define a case as medically futile, our hospital requires that the patient's condition be terminal and incurable, and that the intervention does not improve the patient's discomfort, and that there's no medically reasonable benefit to the intervention. And I thought the interesting part here, which I honestly didn't know before looking into this, but another physician with appropriate expertise must also reach the same conclusion to be able to deny a procedure based on futility. So it's worth looking into your guys' hospital protocols. So when dealing with the futile case, remember that shared decision making is key, and you should assess the patient's values and goals. Also, it's important to touch base with the other care teams like we had chatted about earlier, because their objectives may not align with your assessment of the patient's goals. And lastly, consider getting a palliative care consult if you need assistance in determining the patient's wishes. So we'll go on to our next case. We have a total of 5 cases, so we're just about halfway there. You're on call, and a 20-year-old male patient with his 56-year-old father presents to the ED after a severe car accident with the same injuries. The younger patient is COVID-19 positive, and the patient's father is COVID-19 negative. They both need emergent splenic artery embolization, but you only have 1 IR suite and 1 ICU bed available. The surgeons are all busy operating. Who do you take to the IR suite? So if you want to speak up, again, please just write your name in the chat, and then we'll make you a panelist to be able to speak. If nobody's ready to talk, I will give my perspective. So I think in this scenario, it's tough because on the one hand, people might say, well, the patient's father is older, so he has less life left to live. And so it might be then indicated to take care of the younger patient first. But then if the patient's COVID positive, especially kind of again earlier on during the pandemic when less was known, it's higher risk for more people to treat the younger patient. And I mean, if you're planning on treating both of them, I think that comes less into play. But still, it's something to consider because it might take more time to end up cleaning the room after the COVID, if you're doing the COVID patient first. So there's kind of, it's not clear, but I think in any sort of emergency situation, oftentimes people tend to think about who's going to benefit the most as opposed to who's necessarily the most severely injured, at least during a pandemic when there might be limited resources. So it kind of changes from our regular day-to-day approach, which might be the sickest patient is the one who we tend to go first and tend to take care of before we treat the person who might benefit the most. Does anybody have any other thoughts they want to add?
You know, what's interesting about this question and COVID in general is that these are very real ethical dilemmas that take place in resource poor settings or resource limited settings that we don't necessarily have to think about as much outside of things like organ donation or stuff, but then it's not as acute. And so I think it's been interesting that with this pandemic, it's brought to the forefront in countries that maybe are very resource rich, these sort of dilemmas where, you know, in other settings where people have like, they can only hydrate one person, you hydrate the person that is kind of medium sick, that's going to have the, you know, most chance of benefit, and the other 2 people might succumb to their illness, like with cholera or things like that. So I think that it's a very salient topic to bring up.
Yeah, I definitely agree. And I think an even more timely dilemma that touches on this topic, which is the topic of distributive justice, is the vaccines. So currently, kind of at my hospital, there's a lot of discussion about who should be getting the vaccines first, and across the country that's currently being laid out. So it's hard for administrators and people who are making these decisions to decide, because everybody wants to be first and be protected, and people can make a case for themselves as to why they might benefit the most. The patients, not patients, but workers who are older, who are at higher risk of having complications related to COVID, might say we need to get it first, versus people who are working in the front lines would obviously say that they should be getting that because they're at higher risk, they're more in the environment. But if somebody goes first, that means somebody has to go second. So it's hard to decide. Briefly, we'll again touch on this topic, which is distributive justice, and it's important to know that with limited resources, the indicated treatment might not always be possible. Often, like I had mentioned earlier, the prioritization list changes from the day-to-day norm of focusing on highest acuity to a new norm, which is shifted towards treatment of those most likely to benefit. So again, it's tricky to decide, but there's a shift in kind of the decision making and the triage of what happens, and how to take care of people. So moving on to our fourth case, we have a 25-year-old COVID positive male patient without comorbidities who's found to have acute cholecystitis. You receive a consult for a cholecystectomy tube placement from the surgical team, who elect for a later surgery due to concerns of exposure of their team. How do you respond? And again, I think this topic is a little bit more timely earlier on during the pandemic, when there weren't as many supplies available for people to be able to protect themselves. So kind of if you put yourself in this scenario earlier on, when let's say there aren't N95s available, what would you do?
I feel like this might be worth a discussion between the divisions and maybe hospital administration, because I think it's easy to see your specialty as your tribe that you need to protect. And there's nothing wrong with that feeling necessarily, but it shouldn't be at the expense of other teams, and saying, well, we need to protect my own group, but it's okay if they are, put at higher risk. That it should really be a team effort, and that risk should be distributed as equitably as possible, since we should all be members of the same team: surgeons, interventional radiologists, etc.
Very well stated, Eric. It's almost like you wrote a paper on this. So to briefly discuss the point we're trying to get across in this vignette, tribalism involves behaving in a way that prioritizes your own group of people. In pre-COVID times, tribalism is often used in pushing forward innovation and can be used as healthy competition. But during the pandemic, there's been a habit of risk transference amongst departments, which at times can compromise patient care. So despite the drastic changes that have already occurred in patient care due to pandemic, all departments should consider to make a strong effort in sticking with the usual guidelines, and collaboration and teamwork is the best way to mitigate issues involving tribalism in the workplace. Exactly how you had, what you had mentioned, Eric. So this is our last case. You're consulted on Friday at 5 p.m. to replace a PTC drain in a COVID-19 patient with slowly rising transaminases. Your attending tells you to tell the team to wait until Monday, since he is visiting with his grandparents this weekend and does not want to overly expose himself. You know that replacing the drain sooner would be best for the patient. What do you do? And this case wasn't in the paper. This was something that I wanted to discuss separately. So if you have thoughts on this, please write your name in the chat and we'll make you a speaker. Sarah, did you have any thoughts about this one?
Oh, my hand raises for the first case.
Oh, okay. Sorry about that.
Yeah.
Well, I know I would definitely struggle in this situation, and I have been put in this situation before where you know what the right thing to do is in your mind, and you're told by an attending to do something different. So realistically, I think I would probably try and convince the attending and say, you know, well, sounds like he's really sick. Here are all the stats. I think we should try and do him now. And if the attending kept pushing it off, I want to say I would kind of go somewhere up higher and ask somebody else to try and do the case. But I think realistically, a lot of the pressures within residency might kind of just lead you to say, okay, I guess we're doing it Monday. So it's hard to know exactly what the right thing to do in the situation is. But I think people tend to just stick to whatever your attending tells you to do. And in those scenarios, that can lead to what's called moral distress and injury, which we'll talk about on next slide. Is there anything else anybody wants to comment on this case?
I'm still trying to figure out how to do that tactfully, because there's definitely been times, I just think, you know, healthcare training is difficult. Like you're constantly exposed to these difficult situations, and then as a trainee, when you're put between a rock and a hard place, like how hard do you push, you know? And I'd like to think like with this, you know, like maybe you suggest it, you kind of like pitch the narrative in that way to try and convince them to do it. Or maybe you give them an out and you're like, oh, you know, is anyone else on call this weekend that's maybe not visiting their grandparents that would be willing to do the case with me, because I'd be willing to do it, or something like that. But then at what point do you kind of throw in the towel? Because definitely with some of your other cases, I've had things with like that goals of care stuff where it's like something that clearly doesn't align with the patient's goals of care, and we're just doing it because it's easier to say yes than no. And I've just done it with my attending after pushing a few times, and that sucks. You feel terrible, you know?
Yeah.
I think it's a real issue.
Yeah, and I think again, residents are uniquely put in that scenario because we're physicians and we know our first priority is to take care of patients, but then also you are in a hierarchical system, and you have to kind of default to the people within that hierarchy at times, even though it can feel wrong. So we'll go ahead and chat a little bit about moral distress and injury. So the COVID-19 pandemic has forced many healthcare workers to deal with these high stakes situations and have limited resources, or have had to default to people who are higher up in the hierarchy, which can lead to something called moral distress and moral injury. So although similar, moral distress is actually distinct from moral injury. Moral distress involves engaging in behavior or dilemmas that conflict with your own values and beliefs. Moral injury, although it's similar, it involves death in some way. So for example, you could have moral distress doing a procedure you don't think is indicated, but you could get moral injury doing a procedure you don't think is indicated, and the patient subsequently dies because of your procedure. There's many signs that a patient is dealing with, a colleague or somebody is dealing with moral distress, which includes guilt, frustration, a sense of rejection, difficulty forgiving, self-harm, anhedonia, and shame. And it's really important to be aware of these signs in yourself and in your colleagues to engage in strategies to help overcome moral distress or injury. Some tips for mitigating moral distress or injury include frequent check-ins and social support. Even just having awareness that these entities exist can lead to some psychological preparedness. So we've come to the end. So finally, here's some take-home points. IR physicians and residents make daily decisions which require ethical considerations, and COVID-19 brings many of these issues to the forefront. We talked about each of these ethical issues, and I have provided a few recommendations for how to deal with each dilemma. For duty to treat, it's important to weigh your responsibility to your patients with family obligations and to discuss individual needs as a practice and as a residency program. For cases involving futility, refer to your institutional guidelines and always remember to do no harm. When distributive justice and limited resources are at play, refer to system-wide protocols to help with triage. Although tribalism tendencies are common, it's important during the pandemic for all departments to have a team-based approach. And lastly, to combat moral distress and injury, be sure to debrief early and often. So where can you find more information? This is actually a link which I'll take us to here that has a bunch of guides which you can click on here. We have a bunch of them ready to go for people to be able to utilize. And here's some more resources. This is listed on the Society of Interventional Radiology RFS webpage. It's the IR Ethics in Palliative Care page. So if you are ever interested in and would like to have a quick reference to deal with some of these problems that involve palliative care and ethics, here are some guides that you can refer to. These are 1 to 2 pages long and are a good resource for you to take on the floor. These are my references, and then I would just like to thank the Applied Ethics in IR initiative, which is supported by the Society of Interventional Radiology and SIO. We, like I said, are planning on doing a bunch of these webinars in the future, and we hope to have many more of you come join us. So this is my contact information if you have any questions or comments. Thanks so much for joining.